Well, today we'll be taking a deeper dive in terms of treating anemia in patients with myelofibrosis. Both I'll share some of this information, and then since we really have a representation of the global experts in MPNs here today, I think the discussion will be a very interesting one as how we're thinking about anemia, how we're using new therapies like momelotinib and luspatercept to try to make an impact. So anemia in patients with myelofibrosis is complex. It truly is multifactorial. In every individual, we need to be mindful of the contributing factors. There certainly is a decrease in production from the bone marrow, which is variably present in part of the kind of myelofibrosis process. There can be hypersplenism leading to a shortened survival for red blood cells. There might be occult bleeding that has occurred because of portal hypertension or bleeding varices. There may be pre-existing iron deficiency or nutritional deficiencies, particularly if an individual had evolved, let's say, from post-PVMF. They were iron deficient because of the phlebotomies they had received therapeutically. All of these things can come together. In addition to the underlying causes of anemia, we need to rule out B12, folate, and others. Additionally, many of the medications that can be helpful for the disease still can have anemia as a side effect, particularly with JAK inhibitors. They all, in theory, can cause some degree of anemia, although this is most pronounced particularly with ruxolitinib and fedratinib. Pacritinib and especially momelotinib have the potential to improve anemia, although that is not necessarily universal. So with any individual patient, I'm mindful of what are all of the contributors that are playing a role for the patient, as well as if they've been on other myelosuppressive therapies, such as hydroxyurea. Now, anemia is both common, but it clearly increases over time. And as you see here from these data, at the time of diagnosis, roughly 3 patients in 10 have some degree of anemia, maybe 40% with a hemoglobin less than 10. And there's a subset that require red cell transfusion. So even as we think about anemia, it's always been it's a challenging variable because it is first a continuous variable. And secondly, there's the introduction of the issue of transfusions. Does someone receive 0 transfusions? Do they receive some transfusions? Do they receive many transfusions? A rule of thumb I've used along the way that was shared when I was in training, maybe this is correct, maybe this is an oversimplification, but that the bone marrow makes roughly around 4 units of red blood cells per month. And that if you need much more than that, you probably are having hemolysis or bleeding. And if you have less than the need for that, then there probably is at least some amount of residual creation of red cells, which still is ongoing. Now, the second part of this slide shows that within a year of diagnosis, that level of anemia and red cell transfusion increases. And part of that increase is both potential evolution of the disease, but also really the contribution of the impact of therapy. In particular, ruxolitinib, which again, anemia has been, I think, one of the larger challenges that physicians face in terms of dosing and how to manage that anemia. Now, anemia can have impact on patients in a variety of ways. First, there is that clear decrease in oxygen carrying capacity. We'll talk about that in a moment and how that has an impact on fatigue, on ability to do activities of daily living, on chronic organ strain. But it also has been associated with a decrease in survival. Indeed, with the numerous myelofibrosis prognostic scores that have been developed, anemia is almost a universal factor in terms of being included in those statistical models, with patients requiring transfusions typically having a worse anemia. So you see here on this slide published in Leukemia, again, looking at severity of anemia and its impact on survival, particularly in the setting of transfusion dependence. I think anemia as well is an area where the difference between primary myelofibrosis, post-ET myelofibrosis, and post-PV myelofibrosis does make a difference. Patients with post-PV myelofibrosis, one, are overwhelmingly more likely to have the JAK2 mutation, and two, may bring in some degree of increased production of erythrocytes compared to the other subtypes of myelofibrosis. So overall, patients with post-PV myelofibrosis will tend to have higher hemoglobins, and indeed, they may not be anemic. The flip side of that is when I see a patient with primary myelofibrosis, if they don't have any anemia at all, I'm somewhat suspicious that we really have the wrong diagnosis, or that they have not really progressed all the way to myelofibrosis and really are still in an earlier phase of their MPN. Now, the red cell transfusion patients clearly can have an impact on survival as well. And here it's showing the impact of being transfusion dependent at the time of diagnosis, having a worse survival than those who were transfusion independent. And I think that this is for a range of reasons. I think one is just a marker of more advanced disease. Two, individuals who are transfusion dependent really have a very chronic decrease in oxygen carrying capacity. It probably has a negative impact in terms of stressors on the body. Certainly the actual mechanism of which these patients can pass away clearly includes some degree of cardiovascular mortality that undoubtedly is worsened because of that. Indeed, the individual who is transfusion dependent is really, even after they're transfused, typically does not have a great hemoglobin. They drop to 7 and they go to 9. They're at 8 and they go to 9.5. But their mean and median hemoglobin usually is fairly poor with the consequences therein. Additionally, there's the whole discussion of iron overload. Somewhat controversial really in this field, in that we know, I think, mainly from hemoglobinopathies, chronic iron overload from hemochromatosis and hemoglobinopathies clearly has end organ damage that can accelerate mortality. In myelofibrosis, I think frequently progression of the disease leads to a patient passing away more rapidly than necessarily the iron overload as a mechanism of passing away, but probably is not helpful, most certainly. And there's a clear impact on quality of life. Now, when we started the symptom work with patients back in the mid-2000s, there had been the speculation that anemia was the main driver of MPN-related symptoms. And I'd say that that is probably an exaggeration. I view it more accurately that I think it's a contributor, because we know that patients, even if they don't have significant anemia, still can have issues like fatigue. I do think, however, it still contributes. So if you take an individual that has myelofibrosis and they have a hemoglobin of 7, and you transfuse them and get them to a hemoglobin of 9, they typically still do feel somewhat better. So they clearly has an impact. Likewise, patients that have had improvement in anemia typically do have some improvement in particularly their fatigue, headaches, and some of those things where both a decrease in oxygen carrying capacity and circulatory stresses really are more relevant. So it certainly is a contributor. It does not explain away everything, but it certainly is a contributor. So to summarize, this is a big problem. It's common. It unfortunately has frequently been made worse by some of our core therapies, ruxolitinib having had a tremendously important impact on myelofibrosis, having been the main therapy used largely from 2011 till the current days with the approval of the other therapies, where again, we've really not had a lot of great success in improving that. Two, anemia clearly has an impact for the patient, both in terms of their prognosis as well as their overall quality of life. It also has an impact really on the burden of their medical care. The patient that is requiring transfusions needs to be having frequent blood count assessments. They need to be traveling to the host centers for receiving blood products. It can tether them to their medical center, again, limiting their ability to travel or other difficulties. So that question, there remains an important need for effective treatments to improve myelofibrosis-related anemia.